I'm Francisco Ponce. I'm a neurosurgeon at the Barrow Neurological Institute. And in this video, I'm going to talk about targeting the ventral intermediate nucleus of the thalamus for deep brain stimulation surgery. So here we are on the stealth station. And this is the initial step. These are MRIs that were obtained the day before surgery. My DBS protocol is performed on a GE scanner using SPGR three-dimensional images. You can see 240 slices with and without contrast, proton density, and a T2 FSE. The T2 I do not use. You can see it here. That's the T2. I don't use that on VIM. I will use the proton density just because it's a good sequence to really visualize the internal capsule. So this is the planning of the surgery, of the targeting. I'll be using a CT scanner intraoperatively with a Lexel frame to get coordinates. Okay, so we've verified these. You can see I did not verify accuracy at this step. I wait for that. So here I'll define the image sets and reformat them to slices parallel to the mid-commissural plane. There's AC. I target sort of the mid portion on the posterior border, and similarly with PC along the anterior portion, the anterior border along the rostral edge. And my three midline points are usually floor of the fourth ventricle, and then 2 points along the falx. It's a little bit more than 26 millimeters. And now I'm going to get my starting point, which is just the user-defined coordinates. This is the stealth system, the FrameLink software. So there's a calculation that gives you these coordinates. And this just gets me initial trajectories and targets. So I haven't refined my target yet, but at this point I'm going to make sure that I have a trajectory I'm happy with. So there's the coronal suture, a little bit further posterior. Typically my burr hole is at or anterior to the coronal suture, and I want to avoid a sulcus, I want to hit a gyrus, and I want to avoid blood vessels. And you can see over here the changes, my dragging the trajectory you have on the on the angles. So 15.1 degrees, 64.9 degrees, and now I change my left VIM, drag that so it's more or less as far back as the right VIM. So again, using that little drag box up here to be able to go up and down the trajectory and making sure that we're not going through the ventricle. I usually try to stay about 4 to 5 millimeters away from the ventricle. That's kind of a pearl from Dr. Kim Burchell. So I've turned on the contrast so I can see the contrast imaging. And here's a little bonus feature that's about to come up is, so we've looked at this. Okay, so right now what I'm looking at is over here, look at the anterior commissure. So it turns out, and usually I'll go through all 4 studies and make sure that the anterior commissure and posterior commissure match up right after reformatting, but I skipped that step. And so what I'm seeing right now is that AC and PC don't match up between the SPGR and the SPGR with contrast. So. But before I go back to correct that, I'm gonna fine tune my target. So I usually go about 10.5 to 11 millimeters off the wall of the third ventricle. Places where you can get in trouble with VIM is if you get too close to the internal capsule, or if you go too far posterior and you hit the sensory thalamus and you end up with persistent paresthesias. So that's 10.9 millimeters. You can see it, the ruler shows the number up here. So if I have an error, I'd prefer to have an error in the anterior medial direction. Medial away from internal capsule, anterior away from sensory thalamus. And what I'm doing here is I have added a millimeter anterior to the 25% line. So I start off 25% of the distance from PC to AC, and then I add an additional millimeter to that. And here I'm just rounding these up, getting some round numbers, choosing 14. Typically I don't like to go more than 14 millimeters lateral to midline. If I am going further lateral than that, it's usually because of some atrophy, but the concern with atrophy is even though the atrophy may result in a larger third ventricle, the outside structures may also be have some atrophy, in which case the position of the internal capsule may not be moving so far lateral to justify an X coordinate more than 14 or 14 and a half millimeters. So 14 and a half millimeters is usually my maximum distance off midline for a VIM at the mid-commissural plane. You can see here there's the internal capsule. This is the proton density study. And what I'm looking at here is making sure that I'm far enough away from the internal capsule along my trajectory. So I'm testing to see what it looks like if I move lateral a little bit more to a 14 millimeter mark. It doesn't look like I'm getting too close to the internal capsule at all. Okay, so I like those targets. Now, what I'm going to go back is I'm going to go back and look at the failed merge between the VIM, between the SPGR and the SPGR with contrast. So now I'm going to point merge instead of the auto merge. I think I'll move this over here. So point merging CT to MRI is a little bit more challenging, but MRI to MRI is pretty straightforward because we can see the anterior commissure, we can see the posterior commissure, and you'll see the other points I use. And typically with FrameLink, if you pick 3 points on point merge, and then you hit cancel, and then you do auto merge, it'll use those 3 points to kind of prime the system, and you can usually get a pretty good merge with that. So I'll use the center of the globe. I don't usually use the lens, just because, particularly when you're comparing CT to MRI, the patient may be looking in a different direction during the MRI compared to the CT, and that can throw you off. So I kind of eyeball the middle of the eyeball. So that's a pretty good error right there. So what I'm going to do now is cancel. It's already stored those 3 spots. I'm going to now auto merge. And this is usually successful if there's a big discrepancy between one image and the other through the auto merge. You can see right here, it's not really catching. You still have a significant gap between you can see the fornix right there. So I'm not too happy with that. So I'm going to go back and complete the point merge. So I'll use the other globe. And you can see, even though that's not a specific point, you really have to get a sense, see, all right, is this the middle of that circle? And I look in all 3 planes, axial, coronal, and sagittal. But even though you're trying to pick the middle of this sphere, we're still getting pretty good measurements. See, look at that. That looks pretty good. So those are 4 points. And that should probably be enough. I'm going to use for that little groove right along the optic track. That's pretty good too. And then I pick sort of the first slice where you can see the floor of the 4th ventricle. This is right at the bottom of the aqueduct. Okay, so 0.5 millimeters is my mean merge error doing this point merge. That looks a lot better. All right, so that's the bonus feature here. We had a merge problem that we were able to solve. So this is usually the step where I go through all images and make sure that after all that merging, ACPC matches up. So not huge changes, but now that we've corrected for that merge issue, the contrast MRI shows that I'm a little bit closer to a blood vessel than I thought. All right, so that should be good. So one little trick I do with the Lexel frame is I have a 3rd plan that I make called the right skull entry, and that's basically where my entry point of the skull is where the right VIM trajectory hits the skull, but the target is the left VIM coordinates, so it's a cross midline trajectory, but allows me to identify my entry points for left and right when I'm preparing my skin, when the XYZ coordinates are set for the left side, so I don't have to change the coordinates for the right just for skin preparation. So I'll be doing that shortly. And again, just kind of just double checking that I like what my coordinates look like. And here I'm probably just looking at how on one side I'm a little bit narrower than the other side so far as where that 10.5 versus 11 millimeter mark off the ventricle puts me. Yeah, so now we've done the CT scan. We have the Lexel frame in place. We can see the fiducials here, and now I'm merging everything to the CT scan. So all those, the point merging I did has basically been reset. So now I'm merging all 4 MRIs independently to the CT scan. Now we're doing what we need to do so that we can calculate Lexel coordinates. Volume error looks good here, 0.32. So making sure that all 4 of those studies have anterior commissure and posterior commissure relatively well aligned. See here where that pineal calcification is relative to PC and distance that AC is above the posterior clinoid. I'll usually take a look at that just to kind of get a sense of where it'll lie in case I have to do this on a patient who cannot get an MRI. Usually it's about 17. I think it's a little bit more distance here because the posterior clinoid is a little bit lower. Okay, so and this is what I was just talking about, calculating, setting that third trajectory. That I call right skull entry. Okay, so now we get our Lexel coordinates and we're ready to proceed with surgery. Okay, so now we already have the merge with the MRIs, but now we have our CT scan. So we've placed the 2 VIM electrodes. So the rest of this video is showing the step taken during surgery to verify stereotactic accuracy. turn off the other MRIs, and really what I'm just looking at here is where those electrodes are on CT. Let's get some better windowing here. Looks pretty good. And right side looks pretty good too. So at this point we proceed with closing, as well as annotating the 8 contacts. And this is the step where I document my plan and the final the final contact placements. So for a VIM, I will have 11 images, the ACPC, both targets, left and right, and then all 8 contacts, 4 for each side. Okay, so I'll kind of fast forward through this part and you can see. How the various contacts get labeled. And I'll turn the MRI back on so we have a sort of reference point. There's the internal capsule right here. So here's the ACPC picture. So that's my left VIM target. Right VIM target. And then window the CT scan in. So we have a blend between MRI and CT. You can see I'm a 0.6, 0.4 error at contact 1, and I target contact 1 for VIM, so I have 1 contact below. I'm bracketing the target. And on the left side, we're at 0.3 millimeters off, so that looks good. So that's how I use the FrameLink system for planning a VIM DBS surgery, followed by verification of stereotactic accuracy. And in addition, we went through the steps performing a point merge in case the auto registration does not work. Thanks for watching.